By saying a very, very warm welcome to all our delegates today, our panelists, of course, multi-faculty panelists today who have really agreed and been so, warm in terms of coming forward and being a part of this to help educate our doctors in our society alongside with our collaborated partners for today, the IDA and the BPS, and to educate this whole group of physicians of how we can better take care of our PCOS patients. And with that, let's start off. I would like to just have a couple of housekeeping rules over here that at the end of the session, there will be a chance for all our audience members to put questions in the chat box that Dr. Madhuri will address to our panelists towards the end. If any of our own other panelists as well have questions, then please feel free to unmute yourselves and put the questions forth. We will try our best to have some time at the end of every panel session for some interaction amongst audience and panelists alike as well. So with that, let's start off with the Healthful Mind workshop. Like we all know, PCOS is a condition that we primarily associate with the twin disorders of hyperandrogenemia. Like we know, the alopecia, the hirsutism, the acne, etc., land up at the dermatologist's door. You then have hyperinsulinemia, all the diabetes, the metabolic syndrome, all of which lands up maybe at the endocrinologist's door or maybe at the cardiologist as time progresses. And then, of course, the hyperandrogenemia and hyperinsulinemia, which together cause an arrest of the ovarian follicles, resulting then in menstrual disturbances, subfertility, all of that, which lands at the door of the gynecologist. But we all often tend to forget that what is underlying, no matter where this patient lands up, in whose bucket, there is behind this a lot of body image disorder, there's anxiety, depression, mood disorders, all of that, such that no matter where the patient lands up, all of us the initial contact physicians should be aware about how to eke out this history from our patients and start off with directing our patients, addressing these concerns at the same time while taking care of the presenting symptoms as well. So for that purpose, we have today a great panel, starting off today with Dr. Amita Nene, a quick introduction for all our domain of panelists today. She's the head of in the Department of Pulmonary Medicine at Bombay Hospital, an MD and DNB examiner. She's a program in charge and teacher for the DNB Respiratory Medicine program at Bombay Hospital, multiple authorships, treasurer of the Indian Association of Bronchology, the West Zonal chairperson of the Thoracic Endoscopic Society of India, and recipient of the Young Achiever Award in the field of pulmonology. So Amita, a warm welcome and thank you for being here. Our next panelist is Dr. Anita Sukhwani, who's a consulting psychiatrist with over 23 years of professional experience. She's the founder of the MUN Healthy Mind Center, which has a holistic and team approach to mental health. This is located in Mahalakshmi Temple since 2001, with also a second center in Bandra. She runs a daycare center for patients recovering from schizophrenia, and her interest areas primarily are with children, women, and family therapy. She is the president of the Bombay Psychiatric Society for the year 2020 and 2021. And with that, a warm welcome and thank you also, Anita, for collaborating with us on this. Dr. Milan Balakrishnan is a consultant psychiatrist. I have had the pleasure of knowing him through Bombay Hospital now for many years. He's also at Messina Hospital. He's a postgraduate teacher himself and secretary of the Bombay Psychiatric Society, who has actually helped me put this collaboration into effect today. He's actively involved with many NGOs to fight mental health stigma. And finally, we have Ms. Tara Mahadevan, who is a psychologist. She has a postgraduate diploma in existential psychotherapy from Middlesex University and the New School of Psychotherapy Counseling UK, a master's in psychology. She's an internationally certified wellness coach and weight counselor as well, and a certified mindful eating facilitator running the Am I Hungry mindful eating program in the USA. And with that, a warm welcome to everybody. And so let's get going with our panel today. And I'm going to open the panel today with Dr. Amita Nene. I'm going to address everybody by first name. I think I've become comfortable enough for me to do that. So I'm going to take that liberty, everyone, today. So Amita, starting off with you. Amita, you are a chest physician. And today we have you in here as a sleep specialist. What I want to understand is, what does sleep have to do with the lungs? And what is its impact on health? And as Dr. Shashank has set the stage for us, how much sleep should we get? What's a good way to know that we are having good sleep quality? Over to you, Amita.
Okay, Pia, thank you so much. First of all, inviting me over. Thank you, Dr. Gupta. Thank you, Dr. Madhuri, for this excellent initiative. So, Pia, you've asked a very important question, which every person with a sleep disorder who walks into my clinic asks me, that why am I coming to a chest physician for a sleep disorder? So basically, it's very interesting to know that though we have multiple sleep disorders, the most important sleep disorder which actually affects health is sleep apnea, in which we actually stop breathing during sleep. And because we are not breathing, it leads to low oxygen levels, high carbon dioxide levels, and it really affects our lungs, our heart, our brain, and overall well being. And because the most important disorder of sleep affects the breathing, that is the reason sleep apnea, which forms the most important chunk of sleep disorders, actually has to be treated by chest physicians. And therefore, that is the reason why we are treating sleep disorders also. And it's actually very interesting because, when sleep just came in, I went to Cleveland Clinic to learn sleep, and their sleep belonged to neurology. And I was forced to doing into my neurology rotation. That time I cribbed and I cursed myself. But today I'm really happy because in addition to sleep apnea, I ended up learning all the sleep disorders in great detail.
Right.
So,
So,
and
Amita, to come to the question, how much sleep? How do we know we're getting good sleep?
okay, so ideally, as Dr. Shashank Joshi very well told us, 7 hours of sleep is ideal, and some people could push on to up to 8 hours. But we recommend not sleeping for more than 8 hours because sleeping too much also is harmful. Sleeping less than 7 hours is absolutely not acceptable. You may want to say that my body accepts it, etc. But lots of good things happen during sleep, and therefore 7 hours of sleep is a must. Sleep actually improves your immunity. It makes sure that your memory is correct. All the reparative process happens during sleep, and at the same time, less sleep will lead to heart disorders, blood pressure, diabetes. The quality of life is not good. You actually put on weight because of reduced sleep, and you also end up getting depression, anxiety, etc. So this is the reason why 7 hours of sleep is a must. And you've slept well when you wake up feeling fresh. You wake up and you are feeling fresh, you're charged up, you don't want to go back to sleep. And you've slept well when you're not drowsy during the day. When you're charged up, you can do your activities, you can concentrate, and you can perform well. That is the best way of knowing that you're sleeping well.
So, Amita, a little offshoot there. Dr. Shashank Joshi mentioned 10 p.m. to 5 a.m. None of our lifestyles today are actually allowing that. Our teenagers are awake more. We're all watching Netflix so much more. So would you prescribe the same kind of thing when patients come and ask you this practical question about, I'm sleeping maybe at 1 a.m. and getting up at 9 a.m.? Is that allowed?
Yeah, so Dr. Shashank Joshi said is it's actually ideal. It's the perfect world, which probably 50 years earlier, our parents used to live into, and those people who live in villages today, they do it. But, with today's modern times, very, very many things we know are really good for us, but they're not really possible. So though Dr. Shashank Joshi told us what is the best, and it would be wonderful if we all could really adhere to it. But I would basically say that as far as you sleep for 7 hours at a stretch, and you have the fixed time to go to bed, and you have a fixed time to wake up, it would be good enough with our today's fast life. Because today we want to live completely, and we want to live our dreams also. So to
Right.
make that possible, you may want to adhere to your schedule, but the rest of the world will not adhere to your schedule. And therefore, despite knowing what is better for us, we may not be allowed to do that.
Right. And so from the point of view of, I sleep, let's say, suppose a person is sleeping 6 hours at night and 1 hour in the afternoon. Is that also okay from a 7 hour schedule perspective? Or is that really a bad sleep then from that perspective, Amita?
So honestly speaking, minimum 7 hours of continuous sleep is something
Okay,
that is supposed to be ideal.
I
When
see.
body gets everything to repair itself, it gets immunity to prevent infections, and it actually gives you longevity. So the
Right.
thing is that for some reason, if you don't have the ability to sleep for 6 hours at a stretch, whatever it may be, you have small children, you have school timings to stick to, whatever. In that case, please take that extra 1 hour in the afternoon, but please try to go back, adjust your schedule to such a way that you sleep 7 hours at a stretch.
I think a lot of us have gotten used to that 1 hour nap in the afternoon during this lockdown. So getting back to full scale work might be tougher there. But yeah, that is good advice, Amita. So shifting gears a little bit to what we know as the traditional symptoms of uh, PCOS girls, anxiety and depression. This, like we know, is common. I want to understand, Anita, Dr. Sukhwani, in your opinion, why does this happen? Do you think it's related to a body image perception more than anything else? Is it something to do with the hormonal milieu, the hyperandrogenism, the hyperinsulinemia? Is it the hormonal milieu that is causing this? Is it some neurotransmitter defect, which are the traditional causes? Like all of us have forgotten our old physiology, I guess, but is it a neurotransmitter defect that results in all of this? How would you advise us? How would you tell us about this?
Okay, first of all, thank you very much, Piya. Thank you to the
My
PCOS
pleasure, Anita.
Society
And it's
for
been
having.
great interacting with you. So thank you.
Absolutely. And please call me Anita. Yeah.
I will.
So, yes, anxiety and depression are obviously very commonly seen. Everyone has been talking about it today on the panel. In fact, 40% of the patients who suffer from PCOS suffer from depression. So it is that high. Okay. And you said, what is the cause? I mean, both of them have a cause and effect relationship, anxiety, depression, and PCOS. So I'm going to just relate from my examples because I don't know, in the pandemic, I have had a lot of adolescents, a lot of women coming with PCOS and presenting to me with these symptoms. So on one hand, I have a scenario of one lady coming to me who had no history of PCOS, but she was giving her third year CA exam, and the stress, it resulted in PCOS. She took treatment for around 6 months under a gynac, was fine. 2 years later, got married, and was a very stressful marriage, again had PCOS. And the anxiety resulted in it. And here I have another child I'm dealing with right now, who's an 18-year-old child who was perfectly all right till the age of 12. Pretty, thin, and thin. I mean, everybody called her that, beautiful. And suddenly at the age of 12, when she started menstruating and it started getting into PCOS, her body was swollen up, her upper part of her body became bigger, she developed hirsutism, she developed acne, hair fall, and there was a complete transition in her looks to the effect that people started wondering what is happening to her. And she had PCOS that resulted in a very severe bout of depression because everybody obviously kept pointing out to her what is happening to you and what is wrong with you. So the world around her had changed, her body had changed. So it resulted in depression. So what I'm trying to say is there is a cause and effect relationship between the two, you know. And like you asked, is it the hypogonadism? Is it the insulin resistance? Both result in drop in serotonin levels. So frankly, drop of serotonin levels results in all this. But we don't know what starts first. We don't know whether it is a genetic predisposition, whether it is the environmental milieu, where is it is your internal. So it is a result of everything happening around you. This is where we are today with PCOS. We're also trying to understand where it starts, how to deal with it.
Right, fair enough. So taking the anxiety, depression question, I'd request everybody to mute themselves who is not on the panel, please.
He must be somewhere there only. You can see him, no?
All right. So Milan, I'm going to take this question forward with you over here. So, you know, people who have come to us with anxiety, depression that you see in your practices, you put them on some anti-anxiety medications, antidepressants, whatever it might be. Now, when they come back to my office or wherever else, let's say a derm's office or a gynecologist's office, what they're always trying to do, and I'm sure everybody's experienced this, they're trying to taper down their own medications. They're trying to stop their own medications. We face that with diabetes as well, where people are trying to constantly cut down on their diabetic medications. And I'm sure you see that with antidepressants and anti-anxiety medications as well. So then they'll ask me, Doc, do you think it's okay if I stop these medications, right? So I am always in this dilemma. I try to always push them back to come to you because I feel you are the one who can make the best assessment about their improvement, whether they deserve to come back. We know that this is just a recurring issue, but there's a lot of resistance faced. So how do you suggest we gauge the situation, whether it is fair, unfair? What is your advice to us about this?
Thank you, Dr. Piya, to begin with, I think, and thank you, Dr. Durusha and Dr. Patel for putting together this. I think PCOS is like the conglomeration of all possible specialities that can come together, because it's really can go anywhere. The beginning can be anywhere where the patient may be seen for the first time. And picking off from what Dr. Sukhwani was saying, depression and anxiety is something that will be seen very commonly with patients suffering from PCOS. Again, maybe related is very multifactorial, right? From a neurobiological basis, where we're talking about a hypothalamic pituitary adrenal axis, which is similar to what stress does to the body. So it's a very similar causation to both. To, of course, body image issues and secondary issues that also come into play and increase the risk of depression and anxiety. So important from the perspective of all other physicians when they see PCOS to ask, I think, 4 questions. Very casually, because that's probably the easiest way to pick it up, not like a let's give you a scale and we'll check, which makes it very difficult for patients to really talk about what they're feeling. If we just while in the conversation, while taking a history for PCOS, also just go ahead and ask, or when the patient is starting to talk, and patient usually, once you give them an opportunity to talk, they have a lot of things to say. So quickly ask these 4 questions about, in the last 2 weeks, how have you been feeling most of the time? And do you find that you not enjoy things any longer? This is like a very a compressed PHQ2 questionnaire, which is very useful to pick up depression and anxiety. For anxiety, you also ask about, have you been nervous all this time or feeling nervous for a long period of time? And similarly, do you feel on the edge all the time? So once you ask these few questions, I think you'll be able to pick up depression and anxiety. Now, for the patients who are already on treatment, and again, sometimes medications may be a result of weight gain, may cause weight gain and be like a vicious cycle, there. You would want to, again, taking decisions on helping them reduce the medication is very hard, because there are so many factors that go into it, and we often struggle with reducing medication, primarily because very often the illness is chronic, or on the other hand, other factors may lead to its chronicity, personality factors, that inability to deal with stressful situations, all that may lead to. So I think that decision is a little difficult to take, although I would suggest that it's easier for you to kind of say that, yeah, I know that you want to take off these medications, but let's do it in the best possible manner. Let's try to do it as a, even if they're not willing to go back to the psychiatrist, it would be good to go on a call with the psychiatrist and just have a discussion as to why is the need to continue the medication, or is there other particular reasons. So very often the last episode may have been so severe with suicidal ideation that a psychiatrist would be concerned about tapering off the medication. So those kind of issues probably need to be again going back to the whole multidisciplinary approach that is important in PCOS. I think that would really help in guiding that decision.
Okay. Anita, if you have something to add, please. Yeah.
Yes, of course, I have something to add here. Something very important that we must all remember. When patients come to us, they somehow differentiate, psychiatric illness from a physical illness. What we need to drive home the point with patients is give them the medical model. Why are we differentiating anxiety and depression from diabetes? Why are we differentiating from hypertension? Why are we differentiating it from a knee fracture? So effectively, when you tell a client that you are on metformin while they are for PCOS itself, they will not just stop it, right? They will consult you and then taper it off and get off it. So the same way, if you cannot get rid of medications for diabetes, we cannot get rid of medications for anxiety and depression. Only it has to be under the supervision of the doctor. If the doctor thinks that it is time you've completed your course of medications, then we happily and we'll get you off it gradually under observation. That's one thing we need to drive home the point, because they just love to say, but I don't have any physical problem. Hello, it is a problem. It is a physical problem. It is related to chemicals in the brain and neurotransmitters. Second thing I love telling my patients, and I must know this, I've learned it from my teacher, Dr. Harish Shetty, is depression, anxiety are fractures of the mind. So if Any fracture takes time to heal. You have to give your mind time to heal. You cannot take away the healing by stopping your medications before time. So I think these two things everyone should remember, not psychiatrists, all medical fraternity. That's
I
all I
think
have to say.
we make
Yeah.
notes about how we can counsel our patients on that front. Um,
Yeah.
Tara, this same kind of scenario appears to you from a psychologist standpoint also. Women with acne, hirsutism, excess body weight, they become the targets of bullying, body shaming, etc. How do you counsel patients like this in your practice?
So yeah, thank you first of all for having me, Piya and Dr. Guru and Dr. Patil. I typically see this a lot in my patients. You know, the first thing that I need to do as a psychotherapist is to really just acknowledge and validate where they're coming from. You know, just acknowledging that it is really, really hard today to be a girl or a woman in a world where we're constantly bombarded with messages that we need to, you know, follow or adhere to these unrealistic beauty standards. And you know, these girls have heard, you know, you need to lose weight, you need to lose weight. They've probably gone to millions of dietitians before, but they haven't really understood that the goal isn't weight loss. What we want is really health promoting behaviors. And so, you know, working with them to first acknowledge, you know, I understand where you're coming from, but then also working a lot on body image issues. So like technically just practical exercises that getting them to appreciate their bodies beyond what it looks like, you know, just being grateful for what it does for them, and then of course working with their self-image, right? Because today weight loss has been adopted by the diet and beauty industry to come to mean, you know, acceptability, lovability. And so these girls are sort of, you know, attaching their self-esteem and self-worth to how they're looking. So I work a lot with, you know, telling them that, you know, you're beyond just what you look like, and getting them to appreciate, you know, the strengths they have as a person, the talents they have as a person. So, you know, just in fact, I have a current client who came to me because she was referred by a gynecologist. She had PCOS. She'd been to many dietitians before. But after like three months, I would say, of therapy, she didn't really lose weight. But once I took off the focus on weight loss, you know, started talking about her emotions and then working on her body and self-image, you know, her periods are starting to come more regularly, her acne is reduced. So weight loss isn't really the goal. So, you know, when working with PCOS, we want to, yes, we want weight loss from a medical standpoint, but what we really want is health promoting behaviors regardless of weight loss, because we want them to engage in these behaviors for life. So, and only when people actually improve their body and self-image are they more likely to take care of themselves better. Because if I believe that I'm not worthy, then I'm not going to really engage in any self-care behaviors at all. So that's the focus of my work with women and girls like this.
Fair enough. And what is the role of social media in all of this opinions about girls for themselves? Anita, do you feel social media today has a big role to play in all of this?
Oh, social media obviously has become like the last 7 months, 9 months in the pandemic has become a big thing. And girls who suffer, like Tara says, girls who suffer with body image issues, they are looking at social media for positive reinforcement. The number of likes, the number of hearts, the number of views that they get encourage them further to spend more time on social media, because it positively reinforces their belief that, okay, yes, this person is saying I'm good, so I am going to be good. And it takes them away from their negativity, their thoughts, and, you know, depression, away from already they are bombarded with those thoughts in their mind about their self-image. So social media works as positive reinforcement, and it encourages them to spend more time. The more time they spend on social media, the more addicted and hooked they become, and it takes them away from reality. The hyperconnectivity to social media takes you away from the physical world. Slowly, gradually, they would probably start spending less time with the family and more time on the computer. I know a lot of girls who are sitting and talking on WhatsApp to their families. Is dinner? Mom says, "Mom, dinner is ready. Come to the hall and have dinner with us." And then the answer will be, "No, Mom, I'm going to take 1 more hour. I am busy." So it takes you away from the real world, you know. So obviously, it is detrimental.
Right.
I just have one point to say on the social media aspect is that I feel that because social media content is always mostly happy, and you know, young girls and women are seeing you know, images of perfect perfectly happy women all the time. And like Dr. Anita says, it takes them away from the real world. In the real world, we are going to feel anxiety sometimes. We are going to feel frustrated. We are going to have a range of emotions. And as human beings, we need to learn how to emotionally regulate these. And social media takes away that capacity.
Correct. Fair enough. Another common source of depression, Milan, coming up is basically infertility. So while we like we know PCOS, high, chances of infertility, a big part of our audience over here is gynecologists. So PCOS causes infertility. Infertility is a major, because a woman is looked upon, one of her biggest roles in life is motherhood. The idea, when that 16-year-old girl is coming to your office with her mother, the first question the mother is asking, will she be able to get pregnant? So right from then on, this is kind of, banged into the girl's head. Pregnancy is so important. Now that results in depression. Can depression then worsen the infertility in your opinion? And the second offshoot, let's say, of this is, does all of this then have an impact on sexual function, on libido also, as another psychological output of this whole issue?
Yeah. Taking off from that point on social media, I thought I'd just add one more thing. Social media has become this mirror sort of, where everybody is looking to it to get this feedback again. And so on social media, they also have the option of airbrushing themselves. So to look thinner, to look better, and then so their selfies are better. So then that leads to this complete preoccupation with body image, then, and that kind of adds to a lot of anxiety sometimes for these children who don't want to then go out of the house. They want to be comfortable in their space of just sitting home, sharing things on social media which are airbrushed, but when it comes to facing reality, they're not ready for it. So yeah. And then about this whole issue of infertility, yes, PCOS itself, of course, we know increase the risk of infertility. That eventually, like you were saying, we get a lot of patients who are suffering from trying to sort out their infertility issues and having high rates of depression and anxiety. Depression and anxiety eventually leading to again a loss of interest in sexuality, again from a body image perspective, where they sort of start questioning whether they're loved, whether the purpose is only for childbearing rather than sexual interest in itself. So that kind of starts to hit the libido and affect the libido eventually. And then although there are questions of whether PCOS itself and the androgenic aspects could increase the risk for depression. It seems to be more of a problem with this whole body image issue again coming up, which does affect sexuality and then eventually fertility as well. So working on body image, like Tara was saying, would virtually be at the key of helping with helping people having difficulties with fertility.
Right. Okay. So again, Amita, coming back to you, give us a quick 101 on sleep apnea. How do we suspect it? Are women more at risk? Is it more with PCOS women, obese PCOS women? And a quick, like I said, 101 on diagnosis, treatment, just your take. How should we as non-sleep physicians understand it?
Wow, so it's like a huge thing that I have to talk about, but I'm going to really make it short, concise, and
I mean, all applicable to us as non-sleep specialists.
It's interesting. Apnea is a Greek word. By the word apnea, we mean to be without breath. And when we say sleep apnea, it means the person is not breathing while sleeping. So the thing is that patients who have sleep apnea, the interesting part is that they don't know that they have a problem because the problem is happening during their sleep. And usually it's the spouses who actually point out to them that there could be a problem. So usually these patients are obese. Usually they snore loudly in the night. And when they are sleeping, there is gasping and choking for breath. So the patient may suddenly wake up feeling choked, or the patient is sleeping and the spouse who's awake sees the patient gasping for breath. So these are the things that happen during night. And in the morning, normally, because the quality of sleep is disrupted, the patient wakes up not really feeling fresh, and during daytime, there is drowsiness. So if we have to talk about three important symptoms of sleep apnea, then we say it's a triad of obesity, a triad of loud snoring, and a triad of daytime drowsiness. So if a patient complains of these three things, or if you see an obese person, you ask for these three questions, and if the answers are yes, then the patient has sleep apnea unless proven otherwise. So this is about the symptoms of sleep apnea, which are really common. Then we talk about our women we are more predisposed to. So basically the thing is that for a change, it's really good that estrogens protect us from getting sleep apnea, whereas androgens predisposed to getting sleep apnea. It's interesting because of estrogens, the females put on weight on the hips, on the buttocks, etc., on the stomach, whereas because of androgens, males put on weight below the chin. And when you have weight below the chin, you have fat over there, which compresses on your airway and it makes you get sleep apnea. So interesting studies where we have seen that males have 3 times more chance of getting sleep apnea as compared to women, but this protection is only up to menopause. And once the menopause is over, and because the estrogens reduce, then the chance of getting sleep apnea in women post-menopause is as much as it is in men. Now we know that in PCOD, there is a problem and there are more androgens and there are less estrogens. And therefore studies have shown that females of PCOD have a much higher chance of getting sleep apnea as compared to other women. And therefore we should be actually suspecting sleep apnea in women with PCOS. And we should actually be asking them direct questions. Do you snore at night? Normally, no woman would want to accept that she snores at night. So basically ask the bed partner or tell the family to actually go in the night and record and see if there is actual snoring. You ask them, is the quality of sleep good? Or you think that there's recurrent awakening from sleep? Do you wake up in the morning feeling drowsy? You feel fresh or not? And during daytime, can you concentrate? Are you drowsy? So ask these direct questions. Also, one very important thing we all can do is tell the patient to open the mouth, protrude the tongue out. Try to see if you can see back of the airway. If you can see it, then the patient doesn't have sleep apnea. But if you can't see it, then there's a very high chance that the patient has sleep apnea. Try to even measure the neck circumference. If it's more than 16.5, then the patient has probably sleep apnea. So these are simple hints which can tell us in clinical practice that there could be sleep apnea.
Okay. And so other than these clinical, I think these are very, very good clinical kind of markers you've given us for this. In terms of then making a formal diagnosis, Amita, the tests, are they simple tests? How do we go ahead with testing? Should we be first off referring to a sleep physician? Should we get the sleep test done? Give us a brief outline on, the test and then finally the solutions to that as well then.
So a quick thing. So first we need to know that when we feel drowsy, it is abnormal, because very often we tell the doctor that, I feel sleepy all the time, and we are like, oh, you're blessed, you can sleep well. So the thing is, a patient who complains of drowsiness, this patient is not normal. That is really important. Second thing is that patients who wake up to pass urine in the night, beyond diabetes and prostatic problems, it could actually be sleep apnea, which is causing nocturnal polyuria because of reduced oxygen levels in the night. So the important thing is suspect sleep apnea. Patient is obese, patient is snoring, patient is drowsy, patient cannot concentrate, patient is kind of tired all the time, or patient has disturbed quality of sleep or has to wake up more than once to pass urine, suspect sleep apnea. Now, suspecting sleep apnea is not enough. We need to basically, as I said, clinically open the mouth and see if there's a problem. But also patients who are not obese could be having sleep apnea. So the thing is, there are certain anatomical features, like people could be having retrognathia, they have a small chin. People have micrognathia, a small chin, retrognathia, where the chin is going behind. These two conditions are very, very common in Indians and Asians. And I was involved with the first sleep apnea prevalence study in our country, and we found that patients who had sleep apnea were actually not obese. So we Indians are not obese, but we have sleep apnea because we have a lot of micrognathia and we have a lot of retrognathia. So these conditions also predispose to sleep apnea. Patients could be having a large uvula, a high arched palate, or it could be a child with just tonsils and adenoids. All these things also predispose to sleep apnea. However, suspecting is not enough. You need to confirm the diagnosis, and you need to basically know the severity, because the treatment is based on severity of the problem. So the gold standard is to get the sleep study done, the polysomnography. So we have different types of sleep studies available, but I would say that please do not compromise. Go for the gold standard, which is a complete polysomnography, which involves monitoring of your brain, your eyes, your heart, your breathing, your airflow, your saturation, and your muscle movement during sleep. It's not really expensive. It costs about 7,000 rupees. If the patient is poor, we get it done for 5,000 rupees, also with a concession. You don't really need to get admitted in the hospital. We prefer you do it in the patient's house, in the familiar sleeping environment. So this polysomnography is the gold standard, and you must get the sleep study done, because based on the sleep study, you come to know whether sleep apnea is present or not. You will come to know whether it's obstructive sleep apnea or central sleep apnea, because the treatment for both is different. And most importantly, you'll come to know whether it's mild, moderate, or severe sleep apnea, because if it's mild or moderate sleep apnea, then you need not give always a CPAP to the patient, and you could get away by just giving position changes to the patient or weight loss, or we give some oral dental devices. However, if the patients have severe sleep apnea, then CPAP, the machine that we put it on your nose, is the gold standard, and there is just no compromise for it. There are certain people who have certain very characteristic anatomical problems. So only for a small group, you could actually offer surgery. But the thing is, it's only for patients whose choking is less than 25 times per hour. If it's more than that, however confident is the surgeon, please don't subject the patient to surgery. So this is a small way of treating patients.
Thank you. You've given us the entire thing encapsulated in a sleep apnea for dummies kind of thing. So thank you on that.
Is that treatment is different for every patient. So it's not that every glove fits the same patient. So you have to get a sleep study done. Right. You have to know whether central or sleep apnea. You have to know whether mild, moderate, or severe, and only then you want to treat the patient. So suspect the problem, but please send to a sleep specialist and let the person take over.
Right. Okay. Thank you for that brief chapter for us over here. Milan, since we're talking about the lungs over here, a quick one for you over here. We know that there's a strong association. Milan, you're muted, yeah. There's a strong association, like we know, between PCOS and smoking in so many ways. More than anything else, what I want to understand from you is, what are the options that we can offer our patients as tools for smoking cessation? That is what I want you to tell our audience today.
Right. So I think whenever a patient comes for a problem that could be caused by smoking, that's probably the best time to talk to a patient about smoking cessation, because a patient is, it's very unusual for a patient to present for only smoking cessation as such. So whether it comes to a cardiologist after post heart attack, and then this discussion about smoking cessation comes, or where there may be PCOS and associated smoking with it. So that's a great opportunity to kind of talk about smoking cessation. And so how do you approach it, right? That's the question we have, right? Because with smoking, alcohol, these kind of issues, we are either dismissive or permissive. We don't kind of know the middle path. So we say, oh, theek hai, thoda, if you're drinking, it's fine, or you would say that no, how can you drink? Not allowed at all. So that kind of situation we don't want to be in. We want to be in sense, we need to approach it from a sense of being empathetic, realizing that the person has PCOS, has smoking associated with. Smoking is probably started off as a way to lose weight. Like a lot of friends tell each other that, it's fine to smoke to lose weight. So if you have PCOS, you can smoke in order to lose weight. So kind of approaching it from that aspect is important. So basically, we talk about in addiction or we call it brief interventions, right? Interventions in a clinic that you can quickly do. We have a concept that we call frames. So frames basically is giving a sort of feedback. But I think in frames, the most important thing is the E. E is the empathy, and S is the support. So you begin there and then go to the rest of it. So being empathetic, being available, and saying that, okay, smoking may be a problem here. Would you like me to help you? Would you like me to kind of assist you, guide you in dealing with this? And that I'm available for support even later if you need it. So those are the important parts. Then the other ones are, of course, as a part of frames, the R stands for responsibility, that the responsibility is on the patient. The responsibility is not on you. I am ready to guide you, but you can choose what you want to do. But definitely the feedback part of it, where you tell the patient about the problems that smoking is causing or adding to, or how smoking cessation will make things better for you, is very important. We may not realize the amount of impact that we have on a patient in a session where we're talking about PCOS, but when we talk about smoking, sometimes the patient may really take that very seriously and start working on it. So that's the power as a physician is something that we should not ignore. So these are things that we need to focus on. So the A part of it is, of course, advising about quitting, cutting down. Very often, again, with smoking, it's important to remember that smoking is a very difficult addiction to quit. Compared to alcohol or other addictions, smoking is very strong in terms of the amount of dopaminergic release that it gives you. So it's really hard to quit. So being there to advise, and M stands for a menu of options. So that if you want to cut down, what can we offer you? Do you want to try a gum? Most of them have already tried it, or a lozenge. All of those have already been tried. A patch is quite helpful. I find a patch is quite helpful in practice, because gums give a sort. They don't know how to. They find it difficult to use. They find a lot of side effects, lot of nicotine release excessively, which leads to a lot of giddiness and things like that. So the patch is more sustained in its release. So the patch works much better. And along with it, of course, the fact that that in a follow-up also you will check with them on what is happening in terms of cutting down. Have you found it difficult? Have you achieved some amount of cutting down? And so not being maybe may leave the patient feeling that no, I can't do it and give up. So it's important to just kind of tell them that yeah, we're there for you. Have you managed to cut down? So give them a lot of encouragement in the next time if they manage to cut down. If they found it difficult, we can always ask, what are the difficulties that you're facing? Is it that there is a lot of craving? Is it that a lot of physical withdrawal that you experience? For some, again, it's like the weight gain that happens when they quit. They are very afraid of that part, so they don't want to quit for that reason. So all of that you can address and support them in whatever way. So if you need any added medications for weight loss or additional dietary changes, that can be offered to them. So looking at smoking as a kind of kind of encompassing all these questions together and being patient with them is going to be important.
Okay. And Tara, coming to you, one of the common, maybe things that we see associated with PCOS again is anorexia, binge eating, right? So your area is mindful eating. I want to understand how you tie in all these eating disorders that are so common in PCOS girls with mindful eating advice.
So yeah, so actually I do see, I specialize in food and eating behavior. So I may not see that many people who would be classified as, major binge eating disorder, but more often than not, any girl or woman who comes into my clinic will have some kind of disordered or dysregulated relationship with food. And that's also because of the environment that we live in. And so the first thing to understand about eating disorders and dysregulated eating is actually not about the food or the weight. It's really about control. Usually eating disorders and dysregulated eating manifest at a time when people are feeling out of control of something or many things in their life. And so really getting them to talk about what it is that is going on in life that they feel out of control of becomes the first step, because our emotions then have an effect in our bodies. So that's the first thing that I explained to them is like, yes, I know you're preoccupied with food and weight, but what else is going on? Because there's an underlying psychological issue that needs to be addressed. And in terms of, like I said before, working through that would be working on the body image to get them to see that, we are much more than just our bodies. And even though they're so focused on weight loss, I find that they're not that concerned about their PCOS. They just want to get their PCOS in control so that they look good. So really working with them to understand that we need to just take care of our bodies, whether, however they look, how they are shaped. And I see a lot of people who overeat usually for emotional reasons. So they're working with them to form not just a healthy relationship with their body, but a healthy relationship with their emotions itself, right? So people who are binging or overeating aren't really doing that because they're lazy or greedy or because they don't have time. It's literally because they don't have ways to cope with their emotions. So food becomes one way to numb themselves, to not feel their emotions. So working with them to find other ways to deal with these emotional hungers, right? So if someone is stressed, what are other ways we can work on your stress? We can, exercise, we can call a friend, we can do some journaling. I find that journaling is a technique where people actually then are really clear on what it is that they're feeling. So often we're just feeling this a cloud of anxiety in our heads or in our bodies, but like journaling it out becomes a way to separate ourselves from our emotions so that we don't just become totally overwhelmed by them. And then we really get clear as to what it is that's really affecting me, right? It may be not my body, it may be the fact that I'm feeling lonely, or maybe the fact that, I'm feeling stressed in my job, or I'm not really happy. So working on these issues become more important than just telling someone that, you need to eat well, etc. But that said, I do work with helping them engage in mindful living practices, which would be like the journaling, the meditating, connecting with their emotions. And in terms of the mindful eating, it is really about telling them that it's more important on focusing on how we eat, right? So today we're eating for a lot of other reasons besides hunger. We're also just totally disconnected from when we're eating, why we're eating, whether we're eating because we're hungry. We're all on autopilot. So mindfulness is really about pausing and connecting and taking that space between what we're doing, from moment to moment without judgment. So I would say my top 5 mindful eating skills for my clients would be, one is to just eat in one place of the house. We eat in so many different areas of the house, and many people eat in their bedroom. And actually the bedroom is only associated for sleep and relaxation and comfort. So when we bring food into that equation, what the brain is doing is it's associating eating with relaxation and comfort, and then that becomes a vicious cycle. So whenever we go into the bedroom, we start thinking of food, and so we are then disconnected from physical hunger versus emotional hunger. The second thing would really be to switch off all distractions while eating, because if I'm not fully present when I'm eating, then I'm disconnected from my body signals and I won't know when I'm hungry or when I'm full. And another really important one is I teach them to identify their emotional hungers. So, and feed them with non-food activities. So if I am feeling lonely, then I need to connect with people. If I am feeling bored, then I need to do something that will entertain me. So really identifying our emotional hungers helps us then manage our physical hunger better. So mindful eating is really a smaller circle in a larger circle of mindful living, which is about doing whatever we do with awareness and judgment, and without judgment and presence. So that's how I address this.
So that sounds like we all need to learn up that little bit of the few lines that you have, which I think are very impactful. So Anita, last question to you. I think we have 3 minutes left, and I want to keep this on time. So Anita, your quick opinion, a huge impact, of the high testosterone on females actually with mood disorders, not only from the anxiety part, from mood aggression, which also all of that excess androgen has resulted then in a greater competitive spirit. There's gender dysphoria that we see, which is way more common in PCOS girls. So I want you to give us 2 minutes of commentary on that. And finally, end up this session. I'm going to give you the last thing also, is tips for parenting for parents with PCOS children. So that is going to be my last thing to you, Anita. So take it from there. I've given you a lot to talk about in the next 3 minutes.
Oh yeah, that's a lot to talk about. Before I start this, I want to take over a little from Tara as to, binge eating disorders. And also I am seeing currently anorexia nervosa also. Talking about anorexia nervosa, they're very critical, very sensitive to criticism. this population. So I have seen a patient currently in a scenario that when she came back from abroad from studying, where she was very unhappy, and there were comments passed on her how plump she had become, how fat she had become, or whatever. And she had broken down into PCOS at that time, and that caused her to get into anorexia nervosa, watching her weight, watching her tummy, looking at herself in the mirror every day, watching her food, cutting down her carbs. All that happened as a result of criticism. So we have to be very, very careful. That I'm going to mention in the tips also. Yeah, as to about gender dysphoria, yes, I have seen cases who have different sexual orientation. I am currently treating two patients, two girls, who have mentioned to their parents that they have sexually attracted to their friends, to their girls in their group, and they do struggle with those emotions. They don't know how to deal with it. They're struggling with two things. They're struggling with adolescence and they're struggling with PCOS, which could both be contributing to this difficulties with sexual orientation. So it is very difficult to identify the reasons, but we have to give them time. We have to give them space to understand their own and process their own feelings and get to a reality check of what it really is. So that needs time and patience. Coming to aggression, irritability is one of the symptoms of anxiety and depression. And with higher testosterone levels and with hyperandrogenism, we do see, adolescents, particularly with PCOS, we do see them very aggressive, irritable, specifically if they have an environment which is not understanding and full of criticism. And I've also seen assaultive behavior happening. But whether it is as a result of the imbalances of the hormones or it is as a result of the environmental cues, we don't know. They could all be contributory. As in sports, that also could be a factor that could motivate them towards sports because of the high testosterone levels, they have more muscle strength. So, in fact, I was reading a little about that, and even the Olympics and the Indian Association of Athletic Federations have certain rules wherein they allow female sports persons if their testosterone levels are below only a certain level, which is very debatable and controversial. So we don't know. There is work going on in that area. So as to coming to your last, I am going to take Milan's help on that. A few tips and tricks for parents as to how to deal with them. Remember, girls, women with PCOS are hypersensitive to criticism. Be careful what you say, when you say, how you say. Comments passed by friends and family can be very detrimental and ruin their lives. Be mindful of how you talk to them, what you say. These comments stay with them for life. I have girls coming and telling me, my mother told me you don't look good 10 years ago. I have a child coming and telling me, you ruined my mental health over the last 10 years. I give up on you. I am taking care of my own mental health today. And she has said that to her mother. So be careful. They stay with them and emotionally they mold their personality. So a person who's growing and is exposed to criticism, we've seen them, get into borderline personality disorders where they have no control over their emotions. Then they are already frustrated, angry, and anxious. We're adding to their anxiety and anger by passing these comments. Then take proper treatment. There is something I've really very, very close to my heart. I've been observing this child coming to me and the mother coming to me. They don't know where to go for help. PCOS, like all of you pointed out, is a multi-organ system. It is a multidisciplined approach. We need to educate these children and their parents, and because they don't know whom to reach out to when they need the kind of help that they require. So I am, as a psychiatrist, I'm observing that the mother and child are going from pillar to post. If they call the endocrinologist, they're confused. They call the gynecologist, they're confused. So I think education at the PCOS Society can take it up and educate the masses, educate people with PCOS as to reach out at the correct time and get the correct treatment. And from our end, we need to psychoeducate them. Psychoeducation is very important to make them realize before they slip into depression, anxiety, and binge eating disorders and taking care of their sexual orientation. Before they get into all these problems, we need to be there for them. So psychoeducation and education from all the medical fraternity, I think, is a very big thing today. So that's where I am.
Okay. Thank you very much. In the interest of time, I'm staying with everybody on time. I'd like to give a warm thank you to everybody. It's been great connecting with each of you all at a personal level. And with that, we hand over to Dr. Darusha and our next panel. I don't think we have time for questions today.